talk to us a little bit about how this new line of treatment compares to previous benchmarks that we've seen in the past when you compare your results.
Um, I want to focus now on the Ask for Start study because this was presented first at ASCO 2 weeks ago and then here at EHA. And it had a new endpoint. We developed a new endpoint, which is a very robust endpoint to demonstrate tolerability, the time to treatment discontinuation due to adverse events. That means we have defined a very clear and very strict procedure how to manage adverse events in the Asiminib cohort, but also in the comparator arm with nilotinib to have the same level of actions according to side effects. And if the side effects were not tolerable anymore, then the drug was discontinued. And we expected in this study 65 discontinuations and introduced in the protocol an interim analysis, which was done at 50 events. And we demonstrated that Asiminib is clearly advantageous when we consider this time to treatment discontinuation due to adverse events with 16 events only compared to 34 events in the nilotinib arm. Therefore, with this very robust new endpoint, we have demonstrated the longer and better tolerability of Asiminib. But we looked also at efficacy, but of course it's an interim analysis, therefore we have only 12-week data available. But after 12 weeks, we expect in the recommendations, in the guidelines, 10% BCR-ABL. But what we have seen here is a clear advantage also for the so-called MMR. That's a 3-log reduction of the tumor load compared to the baseline, to the standardized baseline. That means 0.1% BCR-ABL. 2 logs more than the 10% was already achieved with Asiminib in significantly more patients than with nilotinib. That means for tolerability, we have proven the advantage, but also for efficacy.
Um, So when it comes to some of these new line treatments, when we look, I mean, right now we're in Milan, but when we look at treating patients in America, hospitals have different levels of access to medication, access to, molecular testing and things like that. How do you see the need for access to these types of treatments evolving across various countries? What are some of the maybe have you thought about how this might be implemented in places with different
Yeah.
levels of resource?
No, even in places with very good resources, optimal resources, we see differences. We are very jealous in Europe that you have the registration in the US. We don't have the first-line registration for the time being. We expect this for the end of 2025. But at the moment, we don't have it, and we cannot use Asiminib in first line outside of clinical trials for the time being, but we expect this very soon. But the optimal treatment of CML, as you said, includes not only access to all the drug options, but includes also optimal molecular monitoring. And that has been developed in Europe in a marvelous way, in a very good way. We have standardized approaches. We do the molecular testing, the PCR, in a standardized fashion. That means we can compare the data in Italy with the data in Germany, and even the data between different labs can be compared easily. That's not the case worldwide, and as far as I know, not the case in the US as well. And that's a disadvantage for the patient management, because we set our endpoints. We have our milestones, which should be achieved during the treatment in an optimal fashion to achieve treatment-free remission, to know that the patient is on the way to treatment-free remission, and on the other side also to select the patients who are resistant to treatment, need molecular testing for mutations, sequencing, and then an alternative treatment. And most importantly is, of course, the management in treatment-free remission. To do a safe treatment-free remission, we need very clear guidelines when to stop the therapy in a safe way, and then how to follow up to detect an relapse very early, not when it comes to an hematological relapse. That's too late. We need to detect it when the PCR is increasing over time. And with this approach, we have a safe management with overarching, of course, improving the quality of life.